you are still on time, I can say. We are still in the beginning. Our topic of today is concept of pain management. Now we'll go straight to today's. Wait a bit, I'm getting some difficulties. Okay. I'm trying to share my screen. Okay, can everyone see the screen?
Yes, Sharon, go ahead.
Okay, so below are the objectives for today's webinar. We expect everyone who attended this webinar today to have the following understanding. First one is understand the physiology of pain, like what happens to the body till a person is feeling pain. Our second objective is to be able to identify common pain assessment tools, to be able to explore pharmacological approaches to pain management, to examine non-pharmacological interventions for pain relief, also to understand ethical and psychological considerations in pain management. Lastly, also to develop a multidisciplinary approach to pain management. So these are the 6 objectives for today's webinar. I would like to welcome our first speaker, Dr. Alex Elifuraha. Dr. Alex, you're welcome.
Okay, thank you so much. And I'm going to share my, sharing my slides. Okay, good evening, everyone. So today I'm glad to talk to you about pain management, and I'll try to, because it's a very complex. Pain is a universal experience to everyone. It's a complex phenomenon. So I'll try to be as short as to different module outline. So I'll introduce the concept of pain. I'll classify the pain, define and classify. Then I'll, based on both clinical and physical assessment of
Dr.
pain.
Alex,
Yes.
Dr. Alex, sorry, can you maximize your screen? Can you make it a full screen?
Yes. How do I make it full? So somewhere to make it full, where is it?
From the beginning.
From the beginning. Okay. There's something. Okay, there's something. It's not coming. Fine.
No, from the beginning. First up.
Yes, from the beginning. Yes, now there
Yeah, now we can see. Okay.
Okay, so I'm going to talk about the clinical concept of pain, and the most important, the pain is a universal experience, and it's a complex phenomenon. And I'll just discuss on the magnitude of the pain, define it, and I'll classify it and share some pain scales which we use clinically to grade patients. So I'll start with the pain is a complex and common complaint that is attended in the healthcare system, especially in Tanzania and the rest of the world. And I can just share the magnitude around, pass through some of the research that like chronic pain alone affects more Americans than diabetes, heart diseases combined. So it's like annual estimate of 600 billion US dollars is costed on pain. So you can see how big the magnitude is. And as you say, like pain is a complex series of physiological phenomena where if you have an initial tissue damage to pain perception, you have a complex series of chemical mediation from first-order neurons to second-order neurons to third-order neurons, from fast to slow pain fibers, which are alpha and C fibers. So it's a complex phenomena from the brain to spinal cord into the rest of the peripheral neurons. So it's a very complex phenomenon. So pain is often under-recognized, leading to inadequate management on the rest of the world. And most importantly, usually most of the pain which are left as an acute, untreated, whether pharmacological or non-pharmacological, tend to turn to chronic, and with the different chronic pain syndrome, which it's very, very tough to manage, and they need a lot of investment and a lot of multimodality to manage it. So there are a lot of challenges in pain. First, failure to recognize and differentiate pain from anxiety. Some people fail to differentiate. Lack of educational grounds on healthcare providers on how to assess clinically pain and how to grade the pain and how to offer for medication for the pain. Third, there's a safety concern, fear of patient addiction, prescription, legal repercussion, lack of pre-existing physician-patient relationship, inadequate discharge. Like some of the patients that experience pain, when they are discharged from the hospital, they don't get an adequate pain plan. When to revisit, when to be attended, when to use the anti-pain, when to stop. So there's a lot of knowledge gap on the pain management. The other issue is physically unstable patient, like bedridden patient, are least likely to receive standardized pain assessment and to receive pain medication due to poor assessment. Like there's a poor knowledge on the assessment on most of the physiological unstable patients. And also outpatient setting may have limited time to perform full-time pain assessment due to congestion in most of the clinics. So due to financial stress, congestion in the clinic, so there's a very, very poor pain assessment. So you can see if you assess poorly clinically pain, you cannot manage it well. Another issue is some of the stereotypes toward patients with chronic pain being drug seekers, like patients with sickle cell anemia. When they attend to the hospital, some of the clinicians think that they're addictive or probably seek pain medication. But the issue is lack of awareness and education on the proper plan for management of those patients. The other issue is analgesic shortage leading to medication errors and changing protocol. Like if you review through WHO pain treatment ladder, there is a classical pain pathway that you need to treat using different pain modalities. So you cannot execute all the modality if you are in shortage of those medications. So you end up with errors in treating them, under treating them, and some of them complicate into the chronic pattern of pain, which like clinical, they are very, very tough to manage. As I said before, that pain is multidimensional, affecting people physically, psychologically, socially, and spiritually. And some of the pain, some patients' response to pain may be related to genetics, age, gender, ethnicity. So there is a Pandora of pain. Like if there's some like example in age, some people think that women experience more pain or are more fragile to pain than men. Something like some ethnic, some of the tribes, they are not experiencing pain when they hurt. So these are some of the different experiences in pain, and they have clinical implication on both assessment and both clinical treatment of those pain types. And also there's some religious background, there's patient perception, patient expectation, some of the previous pain experience. There are some of the patients that have experienced a highest degree of pain. So treating those patients in our setting is very, very tough. And also there are like different age groups, like classifying pain on children, on adult, bedridden, patient with dementia, a patient with psychosis, like mental illness. It's very, very tough to assess pain and treat them. So it's a multidimensional and multimodality approach that are needed to assess clinically, to define it, classify it, and treat it properly. So I'll go straight to some of the definition and classification of pain that we have at the moment. So determining context of pain, it needs a very, very clear history of presenting illness, and that needs time. So you need to invest some time to assess the patient, take full history, develop a successfully clinical type so that you can treat it effectively. So pain may be classified by underlying etiology, anatomical location, temporal nature, and also the intensity. So let's start with underlying etiology. That means the sources of the pain. What is the source of the pain? Anatomic, what is the location of the pain? Temporal duration, is it acute on chronic, or is it chronic? The intensity, is it mild? Is it moderate? Is it severe? So those classification has an implication on both pharmacological and non-pharmacological treatment of pain. So you have like in our scale, we have like underlying etiology, like nociceptive pain is a result of direct tissue injury from noxious stimuli, like bone fracture, acute burn injury, inflammatory pain like acute appendicitis, rheumatoid arthritis, inflammatory bowel disease, neuropathic pain, and this neuropathy mostly referred like a referred pain, like you have diabetic peripheral neuropathy, you have chemotherapy-induced pain, you have radiculopathy. So knowing this modality, it's easier for you to assess clinically and come up with a proper management plan. We have anatomical types like somatic from the musculoskeletal pain, this from the level of the skin, like laceration, fracture. You have cut wound. Visual type, we call it visual type, visual pain, internal pain, pain from internal organs. And this is very, very important because most of the internal pain, they are poorly localized. So you need to do a lot of investigation to investigate to see what character of the pain, what is it, and come up with a proper diagnosis and treat it, either pharmacological or non-pharmacological. And sometimes this visual pain, you need to move with the surgical intervention. So if it's acute, if it's a pain from maybe colic pain, it's like pain from like you have an acute appendicitis, you need to go in and remove the appendix. If it's the tumor compressing, if you have like tumor compressing the nerve, you need to go and debulk it, remove the tumor. So it needs a very complex assessment, very complex, both clinical, physical, and radiological investigation so that you can treat it. The other is duration, like acute pain that lasts less than 3 months. And you have chronic one, which is above 3 months. Then you have acute on chronic, that you have repetitive type of pain, example in sickle syndromes. Then pain intensity. So like you have mild, moderate, or severe. Classically, this type of pain, like pain intensity, you need a proper scale to come up with a specific type of the pain. And actually, most of these scales, they are subjective, they are not objective. So you need to take a very good history before you classify the type of pain. And how to perform pain assessment. You just go back to medical school where history takes 80% of the proper diagnosis. So you can see in part of our basics that you ask some of the very important questions so that you can assess pain. First, the site of the pain. Second, the onset. Third, the character. Is it burning nature? Is it throbbing like abscess? Is it dull in nature? Is it colic from the stone? Radiation, where does the pain radiated from the limbs, radiated from the upper limb, from the lower limb? Is it cardiac type? Association, what does the pain associated with? Time of the pain, time of the cause, exacerbated, does the pain exacerbate? They move like fracture pain. If you move, it exacerbates, like pain gets more. How does it relieve? Is it relieved by the rest? So these are different mnemonics to help you to take a proper history on assessing the classical pain and come up with the proper type of the pain and the proper diagnosis. So these are different mnemonics. It depends on whether you're coming from the east or west. These are different mnemonics. They mean the same, but they differ on very few aspects. So in the other aspect of when you take the history or when you assess the patient, there are some of the type of the pain you need to go straight to see if is it a medical or surgical issue. First, if it's sometimes it's a hematological pain related to malignancy, so you just come up like you need radiotherapy to relieve this pain. You will give anti-pain, but you need to move also with radiotherapy. If it's a tumor, you need to go to surgery or something else to relieve this pain. If it's from recent surgery, so you need to know it's pharmacological. Probably you will optimize some of the drugs. Is it from some medical grounds? Is it from diabetic? So that means it's a peripheral neuropathic pain, so you need to give some of the medication. Is it from herpes zoster? So you need to treat. Is it migraine? Is it some of the complication from some of the procedure that be done in the hospital setting? So classifying it, whether it's medical, surgical issues, it has 100% implication on the type of the pain and come up with the proper management plan for specific type of pain. There are some of the factors that you need to consider when assessing pain. First is the age of the clients. Age is a very important parameter because if you assess pain in a kid, it's different from an adult, from people with mental illness, different from people with poor cognitive skills, people with prior pain experience, and some of the associated beliefs. Some believe that their specific type of pain, they are related to some of the beliefs. And like in different age, like in kids, because they fear some of the injection drugs, they say, are you feeling pain? No, I don't feel pain, because they fear drugs. So you need to know which patient you are assessing, the age group, level of development, the communication skills, like people with dementia, people with mental illness, cognitive skills, prior pain experience, associated belief. So you need there are some verbal and non-verbal scaling of pain. So you should know how to verbally scale the pain and how to non-verbally scale the pain before you come up with a proper management of plan. So there are some of the pain assessment that you need to go to do physical exams that I said before, like patient with features like acute appendicitis, you need to inspect the abdomen, palpate the abdomen, and come up with a proper management plan. If it's surgery, you go for surgery. If it's medication, you go for medication. You need some neurological exam to assess some neurological type of pain. So there are some pain assessment scales. There are a lot, but I will try to share some of them. So they are different, depend on the age group. Whether the adult, they have their pain scale. Pediatrics have them. Elderly have them. A non-verbal. In pediatrics, you have from neonatal to infant to below 3 years of age and above 3 years of age. So both these scales have different implications on coming up with the proper management plan and proper diagnosis. So like in adult, you have some verbal numerical scale. You have visual analog scale. You have defense and veteran pains. In pediatric, we have different scales. Okay, of course, I will share some of the scales because the time is so short. So I'll try to share some of the pain scale. Like in verbal numeric scale, you ask some of the most important questions and you scale it from 1 to 10. So from 1 to 3, it's mild, 4 to 6 is moderate, and 7 to 10 is severe. So this is the subjective assessment. So you need to take a proper history before doing this subject, but it complements to the treatment plan. The other issue is like patient with dementia. Patient with dementia, because they don't talk, so most time you deal with their facial expression. If they're frown, they are sad, you classify. Facing, grimacing, you classify. Smiling, you classify. Smiling, no pain. They are not smiling, there's pain. So these are subjective ways of assessing this patient. And you cannot come up with one modality scale to conclude, because you need multiple scales to conclude the type of the pain. In pediatric, we have body movement, we have facial expression, We have when relaxed, not relaxed. We have the degree of crying, breathing reflex. If the child cry, that means there's some elicit of pain. So you need to scale the pain. So like it's like in a normal kid, you see like appropriate crying, no irritable, no pain. Crying, highly pitched crying, you score 2. Like something like irritable or crying at intervals, it's 1. So you can easily score this pain type, but they are still subjective. You cannot conclude it. This scaling of the pain. Then we have management of pain. So management of pain is it's a stepwise approach. You have taken a very proper. I would like to know how many minutes do I have? Sharon.
5 minutes.
5 minutes. Okay. So in 5 minutes, okay. So as a medical doctor, because there's a pharmacological context of pain management, as a part of as a clinician, most importantly is proper history taking. Aggressively exhaust the history. Do proper review of past medical history to see if there is history of surgery, history of previous experience of pain, some mental illness, and do some physical examination to see exactly the place of the pain is, assess it properly, quantify and scale it. And then you come up with the proper diagnosis. When you have a diagnosis, then you come up with either is a surgical, because there's some type of pain that will go immediately with surgery. Like acute appendicitis is a straight surgery. Like cardiac pain, you go in, is a triple vessel disease, you go for coronary bypass surgery, then you have relieved the pain. Is a fracture, you splint, you put a nail or you put a plate, you have treated the pain and you put the patient in some of the anti-pain, but you have completely treated the patient. If it's a pain because of malignance, you go for chemoradiotherapy, you treat the pain, you supplement with some of the pain medication, which is going to be the other presence is going to take us through. And then there are some of non-pharmacological approach where like you need to invest to treat the pain. Some of them like massage physiotherapy is one of them, doing massaging. Hot and cold therapy, these are used in treating pain. For those bedridden patients, turning them 3 hourly, it helps them to relieve the stiffness, so you relieve the pain. For some of the patients, actually, you need like a very good language. For children, you need destructive skills, like you give them the video games, play video games, play cartoons, you can relieve them if they have pain. And they will, for some of the kids, if you cannot play games, just take them, like try to breastfeed them. You see, like they have relieved from pain. Those are distraction mechanisms. So you can do massage, you can do distraction, you can do distraction, you can cancel some of the patients, that some of the psychological pain, you can cancel them. If it's a fracture, you splint it. So there are different multimodality of pain management. The other issue is transporting a patient with the pain is another form of pain management, so that you cannot introduce another type of pain. So you should assess the modality of transport from one level to another, from the ward to the investigation unit. So this also helps you in treating pain non-pharmacologically. So if those are logistics grants on approaching different modalities of pain. So thank you so much. It has been good to talk to you in the first part. So I'll let the other presenter share the rest of the pharmacological approach for pain, and I hope to receive so many questions so that we can get some of the answers if possible.
Okay, Dr. Alex, thank you so much for a nice presentation. Can you stop sharing the screen?
Yes.
Okay. It was a nice presentation indeed. And now I would like to inform everyone. Later on, we will give you the form. You'll fill the Google form on how to acquire your CPDs, because I've been seeing people have been asking on how will they acquire their CPD points. So your CPD points, they are secured. You will get them. Tunaweza kutunza maswali yetu, tutayauliza baadaye mwishoni. We will allow questions. So gather your questions. You can type on text. You can wait later. All fine. Right now, I would like to welcome Mr. President for a word. Mr. President, you're welcome. Just 3 minutes.
Hello. Good evening. Can you hear me?
Yes, we can hear you, Fadil.
Thank you so much, and thank you for the ambush. My name is Fadili Ezekiel, and I really am happy to be part of this forum. And thank you so much, our first presenter, Dr. Alex. And I'm really looking forward to learning a lot from the rest of the other presenters and during the discussion, question and answers. Otherwise, I'll just give this time to the presenters. Thank you so much.
Okay, from Father Fadili, Mr. President, thank you so much. Right now, I would like to welcome our sponsors from Planet Pharmaceuticals. They should have a quick presentation before we proceed to the second speaker. I would like also to inform participants on the sharing of the presentations. I've been seeing you have been asking on how you're going to get this presentation for references. They'll be shared via your emails. So after filling your Google form, we'll share the presentations, don't worry. Planet Pharmaceuticals, the one who was prepared from Planet, you're welcome.
Good evening. I'm Saurabh Sabarwal, and on behalf of Aristo Pharmaceuticals and Planet Pharmaceuticals, I welcome you all. I'm sharing my slides. Is it visible?
Yes, we can see, but can you maximize it?
Yeah, I'm doing it. Okay. So today I'm presenting a non-narcotic opioid, butyrophenol. Opioids are classified as agonist or antagonist, and agonists are those that stimulates the action when they binds with the opioid receptors, and antagonist that suppresses the action. So as we know, the oldest opioid which was available was morphine, which is a strong agonist. And to nullify the effect of morphine, there is antagonist, naloxone is available. Today, I'm presenting a product, butyrophenol, which is a mixed agonist and antagonist. So these opioid receptors, these opioids, they give their effect when they bind with their receptors, which are mu1, mu2, kappa, sigma, delta. So different receptors are there. When opioid binds with mu1, it gives analgesic effect. And when it binds with mu2, there are certain side effects of opioids, which you must have seen while you have used it, like respiratory depression, like euphoria. All these side effects are seen. Kappa is another receptor. Some of the opioids bind with kappa and gives analgesia, sedation, dysphoria. These are the effects come. So when we look into opioids like morphine, it's an agonist, which means it stimulates the action when it binds with mu1 and mu2. When it binds with mu1, it gives strong analgesic effect. At the same time, when it binds with mu2, it gives side effects like respiratory depression, sedation, all these things are there. So I'm talking about butyrophenol, which is a mixed agonist and antagonist. It's an agonist for kappa and mu1, which means there is a strong analgesic effect. But it is an antagonist of mu2, which means it suppresses the side effect part. So less chances of respiratory depression, and it doesn't bind with sigma receptors, and that is why less chances of psychotomimetic effects. If I talk about the potency, butyrophenol is 5 to 7 times more potent than morphine, 40 times more potent than pethidine, and 20 times more potent than pentazocine. And that's why if we talk about the equianalgesic doses, 2 milligram of butyrophenol is approximately equal to 10 milligrams of morphine. and 40 milligrams of pentazocine and 80 milligrams of pethidine. As far as onset of action is concerned, it is very fast. If it is given as IV, within first minute of usage of injection, patients start getting the relief. If it is used as IM, between 10 to 15 minutes, patients start getting the relief. Some additional benefits are there. It also gives antitussive effect at a doses less than the required for analgesia, which is helpful in endoscopic, daycare procedures. There is less chances of constipation, urinary retention, because it is a mu2 antagonist. Less spasm of spoon muscles in the GI and biliary tract. There is no local tissue complications, so it can be given as epidurally also. There will not be any skin rashes. No euphoria. That is why less chances of drug abuse is there. And that is the reason in India it is certified as non-narcotic analgesic. The uses of butorphanol. It can be used as pre-anesthetic medications, in balanced anesthesia, in daycare procedures like endoscopy, for the post-operative pain, trauma pain, cancer pain, even colicky pain, migraines, fractures, dislocation, burn, or post-operative pain, even in patient-controlled analgesia also. As far as doses is concerned, if you want to give it as IV, the dose range is 0.5 milligrams to 2 milligrams. However, the general dose is 1 milligram. As IM, the dose range is 1 milligram to 4 milligram. The general dose is 2 milligrams, which can be repeated after every 3 to 4 hours if required. But certain cases like elderly patients, renal insufficiency or hepatic insufficiency is there. Half the doses to be given, like if the general dose is 1 milligram IV, in these cases, half milligram is to be given, and interval is to be doubled. Like in normal cases, we are giving after 3 to 4 hours, we are repeating the dose. In these cases, it should be repeated after 6 to 8 hours. There are certain studies which I wanted to share with you. One study which was published in Front Medicine, Lausanne, 2022. 620 patients of which were undergoing thoracic surgery, butorphanol was given, and it was seen emergence agitation 5 minutes after the extubation was lower with butorphanol, and also there was less pain at the site of propofol injection. There is another study which was published in Indian Journal of Clinical Anesthesia, 2019, where 60 patients of elective laparoscopic surgery was enrolled, and they were given either butorphanol or nalbuphine just 10 minutes before the induction, and the VAS pain score was seen, and it was seen it was lesser with butorphanol at 6 hours and 8 hours post-operatively. So which means butorphanol is more efficacious than nalbuphine as far as analgesic use is concerned in laparoscopic surgeries, because it offers prolonged analgesia. There is another report which I want to discuss. It was published in Journal Anesthesia Clinical Pharmacology. It was in Jan and March 2022. 80 patients undergoing joint replacement surgery. There was 2 groups. First group was given bupivacaine with fentanyl, and the other group was given bupivacaine with butorphanol. And it was seen that butorphanol offered prolonged analgesia compared to the fentanyl. Butorphanol can be used in labor analgesia also, but only in the when the gestation period of 37 weeks is there. So in this study, which was published in JNMA Journal, Nepal Medical Association, 2018, 200 pregnant women were given butorphanol 1 milligram at the onset of active stage of labor, and if required, after 4 hours, the second dose was also given, and the pain relief was noted on a 10-point numerical pain analog scale, and it was seen that there was reduction in the pain from the first hour only, they have observed. And even the APGR score was also seen, which was noted at first and 5th minute, and it was seen that there is no bad effect was there in the neonatal health also. So butorphanol is an effective labor analgesia without any adverse effects on the women and as far as and the neonatal also. So in post-operative pain, butorphanol is very well used. This is another study which was published in Journal of Anesthesia Clinical Pharmacology 2011. 60 patients of lower limb surgery were taken. One group was given butorphanol and other was given tramadol. And it was seen the analgesic effect was better with butorphanol compared to tramadol. And the second thing is this, there is less chances of nausea and vomiting, which is seen. There is another study which was published in Elsevier, where the comparison of fentanyl and butorphanol was done on a patients of abdominal hysterectomy. 100 patients were enrolled. Again, it was divided into two groups. One group was given fentanyl and other was given butorphanol. And again, the VAS score was less in case of butorphanol group when it was compared with fentanyl at the 8-hour. So some of the highlights which I wanted to repeat. Butorphanol is a synthetic mixed agonist and antagonist. It is more potent than morphine, pethidine, pentazocine, or any other opioid. And action is fast. There is low respiratory depression. If at all it is there, it is with ceiling effect. Like other opioids, when you increase the dose, side effect increases. In case of butorphanol, beyond 2 milligrams, it doesn't increases. Conscious sedation is there. Sedation is there, but it is a conscious sedation, which means patient is capable of responding to your orders. So like in daycare procedures, endoscopy and all, it is very helpful. There is low psychotomimetic effect because it is not binding with sigma receptors. Less chances of nausea and vomiting, less constipation, urinary retention, no euphoria. So that is why very low potential of abuse is there. And that's the reason it is certified as non-narcotic analgesic. So for the first time in Tanzania, Aristo Pharmaceuticals, in collaboration with Planet Pharmaceuticals, presenting butorphanol with the brand name Butril 1 milligrams and 2 milligrams. Thank you from my side. If any question or any query is there related to the product, please ask.
Thank you so much, Mr. Saurabh, for your nice presentation. Okay, I can see tuko nyuma ya muda. Sasa ningependa kumkaribisha our second speaker, pharmacist Zawadi Fairs. Okay. Yeah, we can see your slides. Yeah, thank you. Okay. Wale wote wenye maswali, tunaweza kuandaa maswali yetu, tutaruhusu maswali mwishoni baada ya kumaliza our last speaker. Thank you so much. Welcome, Zawadi. Zawadi. Hello? We can't hear you. Zawadi. Also, I'd like to remind you for pharmaceutical personnel, you are reminded by our PST, CPD point coordinator, when you're writing, mkiwa mnajaza ile Google form, kwenye pin number, mnatakiwa kuanza na ile pin number kabla ya kuandika neno pin. Hautakiwi kuandika neno pin, unatakiwa kuanza na pin number yako. Kama inaanza 010, unaanza 010. Usiandike neno lolote mwanzoni. Hiyo ni kwa wale pharmaceutical personnel. Zawadi, are you there? Naona mnauliza fomu itatumwa saa ngapi? Fomu yetu ya Google Form tutaituma mwishoni. Tukishamaliza presentation yetu ya second speaker, we will share our form. So be patient. Kila kitu kitakuwa shared and your CPD, you will get them. Don't worry. Zawadi, you're welcome. I can't hear you. Pamzawadi, are you getting any difficulties?
Nadhani he's trying to share, ila meanwhile from the participant, kwa ambaye ana swali anaweza akauliza kwenye group chat au anaweza aka raise hand, then we can give the speaker to ask the question, wakati tukimsubiria Famzawadi aike vitu sawa.
Karibuni kwa maswali for the last two presentations. Any questions? Abel Ntungi, karibu. I can see you raised your hand. Karibu. Abel? Abel Ntungi, you can unmute and ask your question.
Sorry, I think we need to allow them to unmute, unless I'm not getting it, because for me it is easy. I'm a co-host. I'm not sure whether, Adam, you have allowed all the participants to be able to unmute.
Abel can talk now. Give her permission to talk.
Abel, umeshakuwa unmuted. Unaweza kuuliza swali. Karibu.
Hello, good evening, everyone.
Good evening.
Yes, thank you very much for this nice talk. In fact, it is one of the very important topics, particularly in our society, where by the knowledge of pain management, but also the activeness toward pain management to our patient is very low. And most actually of our patients do succumb sometimes because of the untreated pain. Now, I just wanted to share the experience from the presentation of butyrophenol, and topping up on what Dr. Alex was, concept of pain management. There is a concept of multimodal approach. And I hope my brother Fares will talk about it. Now, the multimodal approach, butyrophenol has a lot of advantage when you consider the multimodal approach, because you're going to use multiple analgesics with a different targeted receptors to achieve the maximum effect of analgesia with the minimal doses of respective analgesic drugs that we'll be using. Now, the advantages with the butyrophenol, actually I use it routinely for all the patients that are in the OT. So intraoperatively, I use it. Why? It gives the advantage that it has a less synergistic effect toward respiratory and sedation with some other drugs. Now, if take an example of if you're using morphine has a maximum sedative as well as respiratory depression to some extent. Now, if you are in general anesthesia, to some extent you are going to use probably benzodiazepine. You will use sedatives like probably propofol. For those who are in limited resources, they will use the ketamine. Now, the combination of benzodiazepine morphine, and ketamine. For sure, your patient may take ages to wake up from general anesthesia. Now, butyrophenol is giving you that advantage that you either give it IV or you give it IM, the required dose, with some other medication. You can use the other short-acting opioids like fentanyl, remifentanil, also fentanyl. And at the end of the day, is how he was saying, like, the patient will wake up from general anesthesia with a perfect satisfied analgesic. Usually they have less complaints. The other thing is, in addition to other modalities like regional blocks and paracetamol IV and NSAID, of which NSAID we usually tend to avoid them because of their side effect perioperatively. Now, butyrophenol, you give it IM while the patient is still on the table, whether you have given spinal anesthesia or you have given regional block, still you give the butyrophenol IM. I usually call it a priming analgesic effect. So eventually, patients, they come out with a high or satisfied pain management strategy. So what I can say is we keep on encouraging each other, knowing the medication that we have around and trying to address these important topics of pain management to our patients. Thank you.
Thank you, Abel, for a nice contribution. Before I go to Dr. Alex, I would like to welcome our second speaker, Fam Zawadi. I think he's ready. Fam Zawadi, you are welcome.
Good morning, everyone. I think now you can hear me from the second.
Yes, we can
Right,
hear
hello?
you. We can see your presentation. You can proceed.
Samahani sana, matatizo ya kiufundi yametokea, lakini nashukuru sasa niko hewani. Nitawapeleka kwa dakika 15 kwenye kuelewa kuhusu maumivu pamoja na effective pharmacological intervention. Nadhani pathophysiology imeongelewa za pain pamoja na zile classification zake. Types of pain tumezisikia kutoka kwa daktari, na sasa tunaenda kujua zaidi kuhusu pharmacological approaches toward pain management. Tutadiscuss pia kuhusu roles za pharmacist katika kumanage maumivu kwa mgonjwa. Tukianza na maana halisi ya maumivu, mfano ukakutana tu na mtu akakwambia it hurts, inauma, inakuwa subjective, hatuwezi kujua inauma kwa namna gani. Either tunaweza tukafanya visualization, tukaangalia anachoongea, anachoonyesha kwa sura, na kuna namna ambapo tunaweza tukaangalia zile assessment kama tulivyofundishwa na daktari. But all in all ni something which is very complex na ni subjective na inategemea na experience kati ya mtu na mtu. Kwa hiyo mtu akikwambia inauma usimchukulie poa. Anaweza akawa na maumivu makubwa sana, yamkini ni mtu ambaye anaweza kutolerate, kuvumilia na au asiongee. Effective pain management is a critical improving ambayo tunatamani kila mmoja aweze kujua, kwa sababu inaweza kuimprove quality of life kwa mgonjwa ama kwa mteja wako na kuweza kusaidia kwenye recovery. A pharmacist is a pharmacist, tunatakiwa kwenye medication therapy management MTM tuwe vizuri, na kwenye patient education tunatakiwa tuweze kujulisha mgonjwa nini maana ya maumivu, dawa anazotumia atumieje ili ziweze kumeet expectation ambazo wanazo kwenye matibabu au kwenye dawa anazotumia. Lakini lazima tuweze kufanya monitoring ya adverse effect, kwa sababu kwenye maumivu mtu anaweza akafika mahali akatamani kuweza kuondoa ile maumivu kwa namna yoyote ile, hata kama ni rahisi sana kuji overdose, kwa sababu tolerance ikiwa ndogo anaweza akafanya lolote, na mwingine anaweza akaamua ikamletea addiction, ukajikuta anatumia zile dawa ndivyo sivyo, ikamletea madhara. Hata matumizi ya dawa katika maelekezo yaliyo sahihi pia na adverse effect. Kwa hiyo ni lazima tujipange tunapokuwa na wateja wetu na wagonjwa, tuweze kujua endapo umempa paracetamol, umempa diclofenac, umempa strong opioid kama morphine, fentanyl, inapotokea overdose, haraka tunatakiwa tumsaidie nini, kwa sababu yeye alikuwa anatafuta namna ya kuondoa maumivu. Types of pain tumezisikia kutoka kwa daktari kwa haraka kama tunavyoziona hizi acute pain, ambazo hizi mara nyingi huwa zina resolve as healing occurs. Kwa hiyo the more unaenda kupona, aidha ni kidonda ama ni umevunjika ama ni umepata changamoto yoyote, the more healings, the more the pain zina resolve. But kuna chronic pain, haswa sisi tunafanya kwenye taasisi za saratani. Kuna magonjwa ya saratani yana maumivu makali sana, arthritis. Walioko kwenye mambo ya orthopedic na mambo ya neuropathy huwa yanakuwa na maumivu makali sana kwenye nerves. Lakini daktari aliongelea kuhusu nociceptive pain ambazo zinaenda moja kwa moja kwenye tissue damage, neuropathic pamoja na psychogenic. Kwa nini tuna assess, na daktari alitufundisha namna ya kuassess, ni zile individual variability ya pain perception. Kwa hiyo ni lazima mtu anaweza kujikuta maumivu yake ni ya kawaida kabisa, lakini personally huwa ni mwoga. Unaweza kumgusa tu kidogo, niachie, naumia, lakini ukiangalia in fact maumivu, classify, assess maumivu yake, maybe anaingia kwenye mild ama yuko kwenye moderate. Sasa ukimisi hiyo kitu, unaweza ukajikuta kwa namna anavyoongea, anavyoperceive ile maumivu, ukatreat kama severe. Lakini ndio maana tumesema ni subjective nature ya pain ambayo ina require assessment. Assessment tumeshafundishwa na daktari pale, ameelezea kiundani, lakini sasa naomba tuende moja kwa moja kwenye pharmacological management of pain. Tunaweza tukatumia non-opioid analgesics, haswa kwenye zile pain ladder. Unajua tunaanza na zile mild pain, ambapo tunaanza kutumia hizi acetaminophen, non-steroid anti-inflammatory kama ibuprofen, diclofenac. Lakini first line for mild to moderate pain ndo tunatumia non-opioid analgesic. Kwenye opioid analgesic ndo tukiona kwenye zile severe pain tunakutana na morphine. Morphine ziko za either being injectable patches, ziwe ni oral solution, oxycodone pamoja na fentanyl. Fentanyl being it injectable or it can be fentanyl patches. Inategemea sasa ni wakati gani unatumia oral morphine, ni wakati gani inabidi utumie injectable. When you are going to palliative patients, we are not allowed to introduce new pain to the patient. Kwa unapomchoma sindano, kwanza ile kitendo cha kumchoma sindano, unajua ni jambo la muda mfupi, maybe ni chronic pain, ni kila siku maumivu yake, anaamka analala nayo. Huwa tunapendelea ni morphine oral solution, fentanyl patches, ambazo wakati una manage introduce new pain. Na kwenye palliative nadhani wataalamu wanafahamu, hatushauri kuintroduce pain. Kwa tunatumia medication ambazo ni salama kwake, lakini zinatumika kwenye moderate to severe pain. Short term use inakuwa recommended kwa sababu ya addiction, kwamba unatumia kidogo unaacha. Lakini these things zinakuwa different tunapokuta kwenye zile chronic illness kama saratani. Uwezo ukasema utakuwa unatumia kwenye short term use. Kuna modality ambayo tunaweza kutumia, una mix, maybe unatumia dawa ambazo ni long acting vis-a-vis short acting, ama ukafanya multimodal, ukampa medication plus maybe some other therapies like physical therapy na nini, ambayo tutaziona huko mbeleni. But sometimes you go beyond that, tunaenda hadi kwenye antidepressant kama amitriptyline. Ukienda kwenye taasisi ambazo zinadili na saratani, utajikuta matumizi ya amitriptyline ni makubwa sana for neuropathic pains ambazo wanazipata. Hata sasa wakati mwingine wagonjwa wa sukari, diabetes patient wanapata maumivu makali sana. Lakini wakati mwingine pia anticonvulsant zinatumika sana kama gabapentin kwenye nerve pain, na muscle relaxant ambazo tunazitumia pia kwenye eneo ile. Kwenye roles of NSAID na acetaminophen kwenye paracetamol, zina reduce inflammation and pain, lakini zina madhara yake. Ndio maana tunasema wakati tunatibu lazima tuangalie, unapompa dawa target ni kuondoa maumivu, lakini ndani ya kumuondolea maumivu madhara au maudhi yanaweza yakapatikana. Ni lazima uangalie haraka haraka ni maudhi yapi ambayo yako expected na ni yapi ya namna gani ya kuweza ku outcome zile. Na kwa mfano kuna GI bleeding kwenye NSAID, kuna cardiovascular risk, kuna kidney damage, tunaweza kujua inapotokea overdose. Kwa mfano hizi NSAID sana sana tunaangalia symptomatically kuweza kutibu, hazina ile antidote ya moja kwa moja. But acetaminophen tunaifahamu, paracetamol mainly side effect itatokea kwenye liver function, na at least hii ina antidote kama N-acetylcysteine. Najua availability yake inakuwa ni questionable, lakini kwenye taasisi nyingine kama Muhimbili na wapi nategemea zinakuwepo. Ni vitu ambavyo tunatakiwa kuviweka standby. But tukirudi kwenye kitu kama opioid, morphine, fentanyl, oxycodone, tunapompa mgonjwa kwenye short term, long term use, tukumbuke inaweza ikaleta some of the overdose, kamletea shida. Haraka tuwe na antidote, kwa mfano naloxone inatumika kwa opioid zote, unaweza kutumia hiyo naloxone kwa ajili ya ku resolve zile side effect. Ile non pharmacological management kwenye physical therapy, physiotherapy, exercise, kwa mfano kuna heat and cold therapy. Haraka kwenye upande wa psychological therapy kuna cognitive behavioral therapy, CBT, ambalo relaxation technique unatumia kwenye mindfulness ya mgonjwa. Unaenda kama sana ambayo inafanana kama zile za tai chi na yoga, tutaenda kukutana nao kitu kama hicho. Lakini kuna complementary therapy, acupuncture, kuna massage, kuna aromatherapy. Kwa hiyo kuna vitu vingi ambavyo inabidi multimodal uangalie, usibezi peke yake kwenye dawa. Kuna vitu vingine unaweza ukavifanya, ukaenda kwenye kumpa mtu kitu ambacho labda kinamuondolea mawazo yake asiwazi ya kufikiria maumivu, akaenda kukutana na kitu anachokipenda zaidi, kikabadilisha ile threshold, maumivu akawa ametoka. Na ndio maana kwenye yoga na tai chi ni therapy ambayo tunazitumia. Kwenye palliative radiotherapy unakuta wagonjwa wengine wanapata mionzi, wagonjwa wa saratani, zinawasaidia kuondoa maumivu ama aggressiveness ya zile chuma ambazo tumeshindwa kuzicontrol. Lakini kuna vifaa vinatumika kama electrical stimulation. Nadhani kwenye baadhi ya hospitali ni chache sana ambazo zina hii style, lakini lifestyle modification kwenye swala la diet na nutrition, ambazo kuna certain anti-inflammatory diet ambazo food rich in hizo fruits, vegetable, kwenye omega 3 fatty acid, zile kwenye mafuta ya samaki, unakuta kuna vitu ambavyo vinasaidia kwenye condition kama arthritis. Lakini kwenye weight management, the more you reduce excess weight, inaweza kusaidia kuondoa pressure kwenye baadhi ya pain. Kumbuka tumesema arthritis ni mojawapo ya maumivu ambayo ni makali. Kwa hiyo huyu mtu akiwa na arthritis na hapo ana overweight, maumivu yanazidi kwa sababu ana impose pressure pale kwenye eneo ambalo linaleta maumivu. Kwa hiyo akireduce weight, unajua nini kitatokea. Na kwenye conditions za mambo kama acupuncture, environmental modification, unaweza kumhamisha tu mtu kampeleka kwenye eneo ambalo anajisikia salama zaidi, analipenda, amekuwa excited, kwa sababu mgonjwa ambaye ana long term huwezi ukarely tu kwenye dawa saa zote. Ukiweza kubadilisha mawazo inaweza kumsaidia. Kwenye opioid management ya pain, tunakumbuka nilisema mwanzoni kwenye saratani ambayo ina severe pain, ambazo morphine niliongelea kidogo, na fentanyl risk zake nilisema, na therapeutic dose, na kama kuna side effect niliongelea kuhusu naloxone. But strategies ni zipi? Use ya long acting vis-a-vis short acting formulation. Kwa upande wa morphine unakuta kuna zile ambazo ni na slow acting ama slow release vis-a-vis ambazo ni rapid release. Kuna nyingine ni after every 3 to 4 hours vis-a-vis kuna dawa nyingine ambazo ni 12 hourly. Kwa hiyo unapofanya technique au strategies inakuwa inamsaidia. Sometimes unafanya combination therapy with hizi acetaminophen ama NSAID. Challenges za kutumia opioid nadhani niliongea kwenye baadhi ya zile side effect, lakini addiction inaweza ikatokea, dependence inaweza kutokea kwa wale ambao wanatumia kwa muda mrefu. At least akiwa kwenye palliative unakuwa hatuangalii sana kwamba ni long term. Tunajua kabisa yeye atatumia kwa sababu tuweze kummanage kwenye primary complication yake, tutamruhusu endelee kutumia kama unavyotumia morphine. Lakini kuna yale magonjwa mengine ambayo tunajua tunaweza kuyamanage, lazima tuangalie hizi side effect ambayo au addiction kutokea na namna ya kupunguza. Tukiongelea kuhusu wajibu wetu sisi kama wafamasia, lazima tuweze kuangalia zile risk assessment, kuweza kumonitor zile sign na misuse, kwa sababu niliwahi kuongelea kwamba the more mgonjwa maumivu yanaongezeka, the more anatamani na ile dozi iongeze. Anapokuwa nyumbani atafanya lolote anaweza kufanya. Kwa hiyo swala la elimu sisi wafamasia ni muhimu sana. Pharmacological nilishaielezea zote hizi, lakini kwenye niliongelea multimodal, namna ya kuchanganya opioid medication unachanganya na physical therapy, au pharmacological unachanganya na non-pharmacological. The more you mix, the more unapunguza matumizi ya dawa zaidi, unaenda kuweza kupunguza madhara yatokanayo na hizo dawa. Kwenye elimu na counseling, empower patient with knowledge and to know kwa nini wanatumia dawa, kwa nini kuna hizi don'ts, kwa nini unamwambia asifanye jambo fulani, inamsaidia yeye kuweza kumanage tatizo lake. Lakini discuss the side effect, usifanye kama ni siri. Manage patient expectation na communicate about potential adverse reaction. Utamwambia itakuwa ufanya hivyo, kwa wakati mwingine itakuletea shida kwenye tumbo, kuna wakati mwingine itakuletea usingizi, kuna wakati mwingine itakuletea dizziness. Kwa hiyo unapomwambia na akakutana nayo, unakuta inaweza kumsaidia. Lakini wakati mwingine tunaangalia kumonitor zile sign of misuse, haswa kwenye vituo ambavyo tunatoa hizi opioid. Ni vema sana tukaangalia kwa mgonjwa anaporudi kwako, ukaweza kuangalia matumizi yake yakoje, pattern yake ikoje, ana misuse ama anatumia vizuri, na kuweza intervene accordingly. Aliongelea daktari kuhusu swala la umri. Unajua kwa mfano kwenye old age geriatric patient, riski ya wao kuanguka ama kuwa na madawa mengi, mgonjwa huyu ni hypertensive.
Hello? Nikukatishe kidogo, muda wako unakaribia kuisha, tunakupa dakika 3 za kumalizia. Najua hapa
niko kwenye
presentation yako.
Okay, asante. Kwenye pregnancy tunafahamu kabisa mara nyingi tunaangalia kichanga, kwa hiyo lazima tuangalie matumizi ya non-pharmacological methods katika treatment ya pain kwa wamama wajawazito. But all in all, nilianza pale mwanzoni kuongelea kuhusu role zetu. Niliongelea kuhusu medication therapy management, kumonitor EDRs, pamoja na kuadvocate pain management policies. All in all, pain is a complex and require multidimensional approach. Pharmacia play a critical role in assessing, managing, and educating patients. Multimodal pain management strategies enhance patient outcome and reduce risk. So, continuous monitoring and collaboration with the healthcare team are the key to effective pain control. Thank you.
Thank you so much, Pharmacist Zawadi. It was a nice presentation, very informative. Naona hapa wafamasia wanaomba tu kupata hizi slides zako kwa ajili ya reference zao huko baadaye. Sasa hivi naenda kukaribisha maswali kwa presenters wote wa leo, kuanzia Dr. Alex Elifuraha, Mr. Saurabh na Pharmacist Zawadi. Karibuni kwa maswali. You can raise your hand, unaweza kutype kwenye chat, tutayaona maswali yote. Vile vile Adam ataenda kushare Google Form ile kwa ajili ya kupata CPD kwenye chats ambayo mtatakiwa kuijaza. Kwa hiyo karibuni sana kwa maswali. Labda nimkaribishe Dr. Alex kwenye ile concept ya aliyotoa Abel ya kuhusu multimodal approach. Can you add anything on that? Ameongelea hapo kuhusu multiple analgesics, titrating doses. Unaweza kuongezea chochote? Hatukusikii.
Abel has actually has introduced, he has said on multimodal approach and titrating different modalities to come up with the proper plan. So what I can say is that was part of pharmacological aspect, which is I can just conclude and say, like, medication only pump you if you have a car which has 4 tires, medication only pump one of the tire. So the rest of the tire, you need another multiple approach, which are like part of non-pharmacological. So he has complemented a lot in the multimodal approach, especially titrating different medication and come up with the fixed one. And plus non-pharmacological approach, you come up with the clear plan and clear you come up with a clear defined plan properly with a specific type of pain, that because there is no a single like there is no a single recipe for pain. It's a multi, so you need to know how to titrate, how to use it, how to slow down, how to move with non-pharmacology and pharmacological aspect. So it's a complex entity, so there is a lot has to be done. So part of education, part of non-pharmacology, part of pharmacological, even transporting patient that I've said before, that is very important, especially patient with pain. So it's something, is some sort of a complex entity.
Okay, Dr. Alice, thank you so much for elaboration of that point. There is one question to pharmacist Zawadi. What are the long-term recognized side effects of amitriptyline use? What are the long-term recognized side effects of amitriptyline use?
Okay, thank you. Tunafahamu matumizi ya amitriptyline tuliongelea kwenye long term use, haswa kwenye elderly geriatric, pamoja na mambo mengine, kuanguka kwa sababu inaweza ikaleta dizziness, ikaleta headache, kwa wakati mwingine inaleta kuanguka. Lakini surprisingly kwa upande wa sexual functions huwa inapunguza libido. Kwa hiyo ni mojawapo ya vitu ambavyo huwa tunabidi tuviulize wakati mgonjwa wako anapokuja, lakini kwa sababu inaweza ikamletea hypotension. Kwa hiyo mgonjwa ambaye pressure yake mara nyingi iko kawaida na anavyotumia tu hizi amitriptyline, wakati mwingine inamletea hypotension, na hatimaye pia kuna wengine wanaweza akaja nalalamika kwako kama inakuwa na ile dry mouth. Kwa hiyo unaweza kujikuta mgonjwa yuko kwenye mionzi, labda amefanyiwa mionzi na hapo anatumia amitriptyline, vyote kwa pamoja vina hadi hapo kwenye dry mouth, kwa sababu inakuwa inamletea shida sana, na ni tatizo ambalo linawaletea changamoto. Na hapa labda niongee kwamba tumepata changamoto ya kumanage side effect ya mionzi kwenye palliative radiotherapy kwenye mtu mwenye head and neck tumors, alafu pia wakati huo anatumia amitriptyline kwa muda mrefu. Kwenye dry mouth ni shida, na ndio maana kuna dawa inaitwa pilocarpine tablet, achana na ile ya macho. Kuna nchi za watu zinatumia hiyo na imesaidia sana kwenye dry mouth. Kwa hiyo sijajua kama kuna taasisi ambayo imefanikiwa kuzipata, lakini tumie nafasi hii kwamba famasi yetu jitahidi hizo dawa zikiweza kuingia nchini zitasaidia sana wagonjwa hao. Asante.
Thank you so much, Zawadi. There is another question here. Adjuvants have role to play in pain management. Adjuvants have a role to play in pain management. Hii nadhani ni comment kutoka kwa Theodora. Theodora, hili ni swali, you wanted it to be like elaborated au ulitaka lijibiwe? You can just type it.
Nadhani huyu ni mdau mzuri wa palliative, ni palliative specialist.
Component.
Yeah, kwa hiyo nadhani alikuwa na add ya point.
Okay, tunakaribisha maswali. Tunakaribisha comments.
Labda nirudi kwa moderator. Sijajua chanzo cha lile swali kuhusu amitriptyline use. Unakumbuka niliongelea kuhusu zile kureduce pain kwa kureduce weight, kwa mfano kwenye arthritis, kwenye joint pain. Sasa ukiwa na mgonjwa wako anatumia sana kwa muda mrefu amitriptyline, zenyewe huwa zinamletea appetite. Kwa hiyo automatically anakuwa anakula sana, inamletea overweight. Mwisho wa siku kama ana shida kwenye joint na vitu kama hivyo, anaweza kushangaa maumivu yanaongezeka kwenye, au tatizo laongezeka kwenye maeneo mengine. Kwa hiyo ni vitu vya kuangalia pia, ndio vile vitu vya kuongea na mgonjwa wako kwamba unapotumia dawa hii, unapokuwa na hamu ya hivi. Siku hizi kuna vyakula ambavyo ni tunasema vinajaza tumbo lakini haviongezi uzito. Tunawashauri kutumia matango, vitu kama hivyo. Asante.
Thank you so much. Tuna maswali machache hapa. Does cupping therapy help in pain management? Cupping therapy help in pain management?
Cupping is cupping is an ancient treatment, like yin yang use of is ancient treatment of pain, whereby, if I'm not mistaken, whereby they use suction, like the burnt area, they use this like a suction to pull a skin so that they can pull blood towards the affected area. And it is believed that if the blood flows to the affected area, it's improved healing, and then the pain goes off. But there are minimal scientific evidence and paper on this treatment modality. So it's the type of treatment modality that is not taking place on the rest of the world, but it's known in the rest of Asian world, but ancient one.
Okay. Welcome, pharmacist Zawadi. I think you had something to add on this.
Hapana, nimeona sina cha kuongeza kwenye cupping kwa sababu to me it's a new thing, ambapo tutaangalia pia huenda ikawa na msaada mkubwa sana kwenye hizi chronic illness kwa ajili ya kupunguza side effects za opioid use, long term opioid use. But kuna swali hapo kuhusu tramadol addictive. Nimependa kwa sababu tramadol ni dawa ambayo the drug of choice kwenye pain management, na wakati ule wa kutoka kwenye analgesic, wakati wa zile mild pain, moderate pain na severe pain. Kwenye moderate pain mara nyingi tunatumia tramadol. Tumetoka kwenye analgesic tunakuja kwenye weak opioid, then tunakuja kwenye opioid, kwenye pain ladder. Kwa hiyo tramadol iko pale katikati, na ni kweli ni addictive, although tumeanza, nadhani tulirudisha kwenye OTC, lakini long term use yake wakati mwingine inasababisha addictive, lakini mechanism ya addictive yake nadhani iko more to the inavyo attach kule kwenye receptors, kwenye zile serotonin nadhani receptors, kuna some sort of that nani situation. Lakini hapo kuna swali ameuliza, je, mama anayenyonyesha hafai kupewa? Nadhani tramadol haina madhara sana kwa mama anayenyonyesha, unless inategemea anatumia kwa muda gani, na pia inamsaidia pia. Kumbuka hata wakati mwingine imekuwa ni drug of choice kwenye wagonjwa wenye ulcers, hatuwezi kuwapa NSAID, tunarudi kwenye tramadol, although ina zile GI disturbances za kutosha. Asante.
Okay. Swali lingine ni, what's your take on synergistic medication versus leveling up on pain relief agents? Zainabas Latha, what's your take on synergistic medication versus leveling up on pain relief agents? I think Zainabas, unaweza kutufafanulia swali lako vizuri. You can unmute and ask. Zainabas Latha.
Anasema hawezi kumute.
Hawezi kuunmute. Adam, unaweza kutusaidia kumunmute Zainabas?
Asante, Sharon. The question here in discussion here was what is the common take? Yani, when you're looking at a double combination or synergistic medications, unakuta kuna watu wanatumia mchanganyiko wa dawa kila mara versus what is the next step in symptomatic relief? Are you looking at using a synergistic painkillers, NSAIDs, or any pain relief agents versus leveling up from NSAIDs to narcotics? What would be your opinion on this? Asante.
Thank you.
Hello,
Okay.
Sharon.
Yes.
Sorry, we have a question here online via YouTube.
Okay.
Someone is asking, what about the comparison with fentanyl and nalbuphine? What about the comparison with fentanyl
nalbuphine.
and nalbuphine?
Hili nadhani atakuja kutujibu Mr. Saurabh, atakuja kushare. From my speakers, kwenye swali la Zainabas.
If you ask me comparison with fentanyl and butyrophenol, I can give you right away. But nalbuphine, we don't have this product. I need to check that what is the specific points of nalbuphine. But if you ask the comparison of fentanyl and butyrophenol, I can give it straight away. Like fentanyl is a agonist and butyrophenol is mixed agonist and antagonist. So like the side effects which we have seen with morphine, that is there with fentanyl as well. The high chances of respiratory depression, which is not there with butyrophenol. And if at all it is there, it is with ceiling effect, which means beyond 2 milligrams, if you go for higher doses, there is no chances of increase in the respiratory depression. So that is a comparison between the butyrophenol and fentanyl. As far as nalbuphine is concerned, I need to check because that is not our product. So I cannot comment right now, but I can give you this comparison. I will search it and I will give it.
Okay. Thank you,
Thank you.
Mr. Dr. Alex and Famzawadi.
Hello.
Yes.
On the concept of Zainabas ladder. He wanted your comments on synergistic medication and versus leveling up on pain relief agents.
Yeah, actually the most important thing is first is to classify the type of pain. Because using synergistic or leveling up, it depends on the classical type of pain and how that pain is actually classically relieved. There are some type of pain you need multimodality medication. You need to sum up two type of medication with two mechanism to treat it. So it depends on the facility level and the availability of those multimodality drug. If they're available, you can use both of them, or sometimes you can move out the maximum dose if you you have only limited options. So it depends on the option. So those are both good ways, but you need to you weigh risk and benefit, and then you assess the level that you are in, if you are capable to do it or not. So it depends on the facility investment. If they have both, then you can use them and so it depends on how you titrate them, weighing risk and benefit.
Thank you, Dr. Alex. I'll go to the next question. How do you address pain management in patients with history of substance abuse? These questions, I think Famzawadi will give a very good explanation on this, kwa sababu kwenye presentation yake kuna sehemu ameongelea addiction. Famzawadi, you're welcome.
Oh, hello.
Hello, we can hear you.
Yeah. Naomba urudie swali.
how do you address pain management in patients with history of substance abuse?
Okay, that's good. Kwenye zile approach nitaelezea kuhusu suala la education na monitoring. The more you educate your patient, they know the one who is being addicted na bado you need to manage pain ambazo anazo. Kitu cha kwanza ni elimu. Unapokuwa umempa elimu, hata kama ukaenda kwenye substitute na ukaenda kwenye multimodal ile ambayo nimekwambia zile non pharmacological, kwa sababu kumbuka inabidi uende both, unarudi mgonjwa umpeleke kwenye zile non pharmacological approaches ambazo zitamsaidia kupunguza wa pharmacological approach, yani matumizi makubwa ya dawa, lakini pia unaangalia objective of the pain ambayo unaifanya wewe. Kama ni palliative, huwa hatuangalii sana kwamba ana develop addiction sababu ni palliative, lakini mgonjwa ambao sio palliative ni lazima urudi kwenye kuchange medication na pia wakati mwingine kushare the effect ya ile dawa, lakini pia kuna withdraw. Ndio maana tunawapeleka kwenye kama kwenye methadone, kwenye nini, kuna wakati inabidi uweze kubadilisha ile dawa ambayo yeye ameizoea, lakini umpe alternative ambayo yeye kama yeye utakuwa umeshampa elimu na anaweza kuitumia vizuri. Nadhani kwa kifupi niseme hivyo.
Thank you, Pharmacist Zawadi. Next question is straight to Dr. Alex. What are the ethical considerations in managing pain for terminally ill patients versus those with chronic non-terminal conditions?
Okay, so that's actually a very tricky question because actually you are talking about goal of like end of life care, terminal ill patient. So our role as medical doctors and clinicians is to prevent and relieve suffering as much as possible while respecting the desire of the dying patients. So we need to do everything, we need to do everything possible for the benefit. We need to do everything possible for the benefit of the patient. And here in our author, there's something we call it do not harm. So as much as the patient is feeling pain, we will give pain medication as much as possible. And we will, the other important component is family involvement. So the decision has to be made with the patient family members and the society as well, and the patient. So there is like a conference, like we are giving this, we know there's some sort of addiction, but we need to relieve pain. This is not the country that we have those laws of illicit, like inducing death, like suicidal, inducing death to terminally ill patients. So we will have a very open communication, shared decision-making process among healthcare providers around the patient, him or herself, family members, so that to avoid a lot of ethical dilemmas around. So it's a Pandora of its own. So it's a complex entity. For those of non-terminal ill patient, we will treat them with different multimodality approach, pharmacological and non-pharmacological. But for those terminally ill patients, we'll have open communication with the family members, with the society, healthcare providers around the patient and the patient him or herself, to see that we are giving this drug. We know there's this complication, but we are trying to deal with, like, you know, like painless ending her life, him or her life. So we will try to protect the right and dignity of the patient, and we'll ask the patient here his opinion, inform the decision. If the patient accepts, we'll give them. We try other means and other approach, but this is the only way that we can do multimodality approach, open communication, shared decision-making process among the members around the patient. So it's a Pandora of its own.
Okay. A very tricky question and a very tricky answer.
Yeah.
Okay, another question. I think this is Dr. Alex's question. Why pethidine is not preferred to be used as analgesia during operation? That means while the surgery is in progress.
Of course, this should go to the pharmacist, but what I know is that pethidine has some respiratory depressive effect, and that might complicate the patient. So, like, they have respiratory depressive effect that probably with the medication that patient is given during anesthesia, there is some sort of drug interaction that might affect respiratory pathway of the patient.
Okay. We also need opinion from pharmacists.
Yeah, this is straight to the pharmacist.
Everyone, participants, anyone who can contribute on this. So this is about a medication, and we are the medication experts. Wakati tunaendelea kulifikiria hilo, Mr. Saurabh, there is a question for you here. On the medication that you presented, butorphanol, does it help to treat or reduce dyspnea, difficult in breathing? I think
no, it doesn't help in dyspnea. You know, this is not for that purpose, and in fact, there may be some chances of respiratory depression will be there with this also being an opioid. So it is not going to help in dyspnea. It is not like that. Rather, like other opioids, there is certain chances of compared to other opioids, it is less, but still some chances of this is there. But no, it is not going to help in dyspnea.
Okay, thank you.
In fact, if you know, if some patient is asthmatic, then it should be used with some caution.
Okay, is this butorphanol available in the market?
Come again?
Is this medication, butorphanol, is it available in our market?
Yes, it is available in Tanzania, and it is being promoted by Planet Pharmaceuticals in Tanzania. So it is available. Both the strains are available.
Okay. What is your opinion on the use of combination of diclofenac injection and tramadol injection? Hasa kwenye local facilities wanatumia sana muunganiko kwenye kutibu maumivu. Opinion on the use of combination of diclofenac and tramadol. Zawadi, welcome.
Ni kweli wanatumia, sijui kama nasikika, lakini unapotumia NSAID na ukatumia weak opioid, one of the strategy au objective yako unataka kumiti ni kwamba uweze kumanage pain with lower side effect. Unapochanganya non-NSAID ambayo inaenda kuinhibit zile prostaglandin vis-a-vis opioid ambayo inaenda kwenye opioid receptor, mechanism of action zote kwa pamoja, kumbuka, ziko tofauti. Kwa hiyo synergism inakuwa created hapo. Kwa hiyo kama unaenda kucheki kwenye inflammation, kwenye anti-inflammatory, unakuta umesha handle vizuri na hii diclofenac, na utapunguza dependency ya kutumia zaidi opioid. Inakusaidia sana wewe kukaa hapo muda mrefu, kwa mfano ni chronic illness au pain, kabla hujaenda kwenye strong opioid. Kwa hiyo inaweza kuachieve. Nakumbuka kwenye hizo lower facilities wana avoid kwenda kwenye hizi opioid kwa sababu kwanza ya availability na cost. Kwa hiyo pia unaweza ukamsaidia huyu mgonjwa. Diclofenac ni cheap, tramadol ni cheap, kabla hujaenda kwenye, kwa mfano hiyo butorphanol ukiangalia ina both, ni partial, ni agonist, antagonist, ni nzuri, lakini kabla hujafika hapo unaanza kwanza na hizi low, na ndio maana halisi inakuja hapo ya ile pain ladder. Utakapoweza kuassess na kujua, so unaanza kwenye weak, unakuja kwenye moderate into strong. Asante.
Thank you. This is the last question, and it will be a last question for today. Kwa sababu muda umetutupa mkono sana. Kuna mtu anauliza, how can you manage pain due to pregnancy induced hemorrhoids? The question said, presenter said in pregnant mothers we avoid medication and prefer non-pharmacological pain management. How can you manage pain due to pregnancy induced hemorrhoid?
You can use local lignocaine.
Okay.
Yeah, you
Yeah.
just target it. And actually, most of the pain in hemorrhoids, actually, they are not hemorrhoids related. They are from fissure. So you can also use nitroglycerin, which will do some dilatation, then you'll get some relief of pain. So most important, you can use just lignocaine gel. It's more than enough. We have prescribed to thousands of pregnant women, and it works well.
Yeah, I wanted to add on that also. Yeah, kweli in pregnant women we usually use local kama hizo alivyozistate Dr. Alex, lignocaine gel, lakini pia kunakuwa na hiyo glycerin trinitrate ambayo inasaidia kufanya relaxations ya zile muscles inapunguza
Muscles.
Lastly, Abel, you raised your hand. Adam, unaweza kusaidia kumunmute Abel aulize swali lake la mwisho to wind up.
Nilitaka tu nijaribu kuclarify. Nimeona kuna swali moja mtu anasema kuwa pethidine haifai kwa ajili ya operation, wagonjwa ambao wako kwenye operation. The answer is no. Pethidine can be used intraoperatively. The only issue ambayo actually watu wengi wanaogopa pethidine hasa na morphine saa nyingine. That's why wagonjwa wengi wanakuwa operated with the poor pain management. It's like their side effect are more pronounced after the surgery. Unakuta ndo iko kwenye peak. Kama mgonjwa alikuwa kwenye general anesthesia, they will struggle waking up from general anesthesia, na matokeo yake utakuta wanaitisha na Roxone, of which sidhani kama huwa ni sahihi sana. So watu wasije wakaogopa kuitumia pethidine intraoperative kwa kusema kuwa labda haifai. No, inafaa. If you are limited, you have pethidine as one among the strong opioid kwenye facility yako. Tumia. With the only caution in neonates, wale neonates kushuka chini, na elderly. Sasa si elderly kwetu hapa inaanzia ngapi? Si 65 au ngapi? So from 65 and above, you start considering like pethidine may not be safe to this patient because of the chronotropic effect, na umri huu wako na high risk za kuwa na myocardial infarction and things like that. So if the pethidine bring the chronotropic effect, hawatakuwa na muda wa kuperfuse their coronary. So chances za kwenda kwenye MI zinakuwa ni kubwa zaidi. So otherwise kwenye other group, if you don't have any other strong analgesic agent, please don't hesitate to use pethidine. The other thing is kwenye kwenye hiyo ya hemorrhoids, probably pudendoneulalgia and things like that. Yes, tunatumia hiyo kama aliyosema Alex, hiyo jelly ya lignocaine, but also usually hemorrhoids huwa inatokana na thrombosis effect. Okay? Where I was learning my pain management, one of the strategy was to apply jelly ambayo inaweza ikatoa chances. Sometimes they tend to improve if just thrombosis was the major issue, kwa kutumia heparin jelly again. So the lignocaine get combined. There are lignocaine which are combined with the heparin. Okay, you can apply that. Lakini if you are at the facility where the management of patient is top notch, huwa tunafanya pudendo nerve block ambayo we can infiltrate a little steroid ambayo inakuwa ni locally just behind the ischial spine. Inakuwa ni locally, mama anakuwa na relief ambayo it can last for 3 months and above. So wanakuwa na hiyo faida. The other thing is kwenye synergism ya diclofenac na tramadol. Now inatumika sana because moja notion tulionao ni kwamba tunaogopa pethidine, matumizi ya pethidine. Na Fares, ni kuondoe wasiwasi kuwa pethidine and morphine is not expensive compared to hizo tramadol na diclofenac ambazo tunaweza tukawa tunafikiria like the alternative. Pethidine is too cheap. Okay. Morphine likewise is too cheap. Na availability is limited. Bahati nzuri leo niko kwenye group la wafamasia, naomba niwaseme hapa. Availability is limited kwa sababu ya nyinyi wafamasia ambao mko responsible na dawa, hasa kwenye hospitali za wilaya na huko nani. Watu wangu wengi wanalalamika kuwa wafamasia mnawaambia hiyo dawa sio level yako, you can't use it. Please let us help jamii yetu, tusaidie wagonjwa wetu. Pethidine can be used even at lower facility level, provided the providers wanaelewa dawa gani wanayotoa. Na matumizi ya naloxone is almost zero if the drugs are used properly. Thank you.
Thank you so much, Abel.
Thank you so much.
For a very insightful comment. Thank you everyone for participating in this webinar. Thank you, Dr. Alex, for a very insightful presentation. Thank you, Pharmacist Zawadi Ferris. It was a nice presentation, very informative. I would like to welcome Mr. President, Pharmacist Fadhili. If you are there, we are welcome for the closing remarks.
Thank you, Sharon, and thank you everyone, participants who spent all these minutes just to learn from the speakers. A lot of thanks to the sponsors who made this forum possible. And maybe I start with the last speaker, the last contributor, who actually highlighted the gaps that are there, especially when it comes to supply chain and the level of the medicines to the facilities. And I would like to thank him very much for such an highlight. We have taken it, we'll work on it so that we make these medicines available as per the guidelines and regulations that are available. And if need be, maybe advise the change of the policies and the guidelines. What I want to highlight here is that this world of medicine is changing very much. And therefore, I will want to call upon every one of us who is here to always be on the lookout of these kind of forums so that we are going to be together learning on how we can help our patients. And I like this kind of the approach that we've used in this, and I think the last forum, where we have both doctors, nurses, and pharmacists coming together and discuss. This in itself is a success when it comes to the health system, because we all serve that patient, and therefore we all need to be on the same page when it comes to what we need to be doing to help the patients. Otherwise, I would like to thank every one of us for being part of this forum, and looking forward to seeing you again in the next forum that we will prepare. Thank you so much for the moderator. Thank you so much for the organizer and everyone who is involved in making sure that this is a success. I wish you all the good evening. Thank you.
Thank you so much. I would like to remind participants to fill the Google form that's been sent on the chat side. It has been sent even right now. Just fill it, fill your details. For pharmaceutical personnel, don't write the word PIN before your PIN number. Just start writing your PIN number. Like if it's 010, write 010. Thank you so much. Thank you, everyone. It was a nice and interactive session.
Thank you. Bye-bye.
Bye.
Nani unasema gani?